where the wire is, it's just looping around. So sometimes injection is really, really important to give you an idea like which way you have to go. ठीक है? तो इसमें if there was no injection, if I don't know which way I have to go, and just trying to do only with the wire cannulation, I would not know if I'm in the right place or not. एक और दूसरी चीज़ कल I was talking about this septum. We talked about that. ठीक है? Sometimes you are cannulating and you keep getting into the PD in spite of being in the right place. You are maneuvering your sphinctertome tip up. You think you are in the right place, but it just keeps going into the PD. So what happens is, वो pointer किधर है? So for, what happened is like, let's suppose this is the papilla, okay? This is the first position of the papilla. Septum is right in the middle, bile duct is above that, pancreatic duct is below that. So you cannulate it, you went straight into the PD, okay? What happened with that is also the case with the bile leaks as well, when the system is closed and sometimes you just keep going into the PD. So once you cannulate it, you put your sphinctertome into the orifice, and then what happens is septum moves up, okay? And it can get kind of plastered, that may be the right word to use. It gets plastered to the upper wall. Now, bile duct is really a very, very small area here. No matter what you do, you just keep going into the pancreatic orifice. So just keep that in mind. Like if you are just going into the PD the whole time, that may be the problem. The way to overcome that is you just use a wire tip, no cannula, just the wire tip, and go to the upper edge of the papilla or the orifice and try to get the wire up right underneath this in there. And that's how you are going to be able to move the septum down. Okay. So ये इसका जो है ना, this can happen with the bile leak. That's why sometimes the bile leaks are a difficult cannulations. I don't know what your experience is, Saad bhai, about the bile leaks. Those could be a difficult cannulations, and especially because it's a non-flowing system, and it's easy for the septum to get stuck up there. Yeah, longer the period, worse the cannulation. And quite. So what I have noticed over the period of last 4 or 5 years is that whenever I have to use the needle knife, a lot of those patients are bile leak patients. That's where I have to usually use it. Okay. So now we have tried every standard technique. If that standard technique fails, then what to do? You have to do something else. If one thing is not working, you have to change it. So doing the same thing over and over is not going to help. So you can, if you keep going into the PD, you can place a wire there and do a double wire technique. It could be inverted as well. If you want to do a PD work, and your wire keeps going into the bile duct, you can leave a wire there and use a second wire for the pancreatic duct. So either way, but mostly a double wire technique, what the term is used is you keep going into the pancreatic duct, you put a wire there, and then use a second wire to go into the bile duct. So what that does is really, it straightens the papilla for you, that wire. First, it may be floppy, it may be facing downward, and it kind of aligns and brings the papilla and the bile duct into the axis of cannulation. So that's why it's helpful. Other times you can place a stent. Whenever you place a stent in the pancreatic duct, usually it's helpful with the biliary cannulation, but sometimes you can make it worse for yourself. And the reason is the same thing. The septum goes up, and now you have completely shut it down. So sometimes it could be a problem, but With the pancreatic stent, now at least you have saved the pancreas, and you can do some other technique like needle knife if you have to. That way the pancreas would be safe, less risk of pancreatitis. For any reason you have to stop the procedure, patient is unstable, or bleeding happens, at least pancreas is safe in that case. Other is, you guys have the curved wire. Have you seen that? I think they should have it here. It has like a loop wire जो जिसको आप कहते हैं. So it's a little curved. So that gives you a different angle. You can use that. I use that all the time. And especially even if I have, after cannulation, it's a hilar stricture, or I'm not able to go into one system, or if I have to go into the cystic duct, which happens quite often too because of a cystic duct stump stone or something. So if I have to go into the cystic duct or during the spyglass, I use that curved wire to get an angle into the different duct. So this is an example of the picture, I should say, of a double wire technique. You can see the wire is, so one of the wires is in the pancreas, and that what that does is that kind of straightens the papilla for you so you can get into the bile duct. Okay? So what to do if I really fail in cannulation? You can do an access sphincterotomy or a pre-cut. You can do a PTC rendezvous or EUS guided rendezvous. So here and there, once in a while, I have to do a rendezvous, and but I use a EUS to do that rendezvous during the same session. Okay. I don't think we need to go over the needle knife, right? No? Okay. Okay. Yes. So with regard to, I mentioned some points about that, like why it's important to place a pancreatic stent prior to, if you have to really do a access sphincterotomy or pre-cut sphincterotomy. One thing is it provides you a direction of the cut. The papilla becomes a little more apparent. Also, it helps you to limit the depth of the cut and stabilize the needle knife. So a needle knife, not the topic, but still, you cannot be too superficial, you cannot be way too deep. So it has to be a right length of the needle. You cannot just do the mucosa cut and hoping that you're going to get into the bile duct. So it has to be a very, you have to be careful about that. And what the stent does, as I said, if for any reason you have to stop the procedure, bleeding happens, patient is unstable, you have to stop the procedure, at least your pancreas is safe. Okay. And here is the example of a PD cannulation. So here, if I really have to do a pancreatic work, and I usually don't like a sphincterotome for that or a bigger wire. I usually use the smaller wire, either 018 or 021, and then use this catheter. There are different, this is 543 cannula, means 543 is it's a tip is 3 French, a little bit back 4 French, and overall the catheter is 5 French. So this is my favorite for pancreatic cannulation. And or you can use a tendon XL. I think you have that, the other regular cannula. I try to avoid the sphincterotome because it's way too big for a smaller pancreatic duct. Here, if you pay attention to the like position of the scope, papilla is this way, right? So if papilla is straight, to go into the bile duct, you go close towards the 11, and for the pancreatic orifice, you go towards 1 o'clock. Here, I moved the small wheel towards me so I can go straight into the pancreatic duct. So that way I don't have to worry about, I changed the position of the papilla with the scope, with the wheels. Mainly it's a small wheel, and by pulling the scope back a little bit. So after you get into the pancreatic orifice, I think it should not be a wire-guided cannulation in the pancreas when you are intended to. Bile duct does not have branches. Pancreatic duct has a lot of side branches. If you put a wire into the side branch, you can perforate that side branch. And that's where there's going to be a leakage of the pancreatic juice and pancreatitis, in spite of putting a stent in there. So if you are in the PD, that's your intention to go into the pancreatic duct. As soon as you get into the pancreatic duct, inject. Get an idea about the anatomy, which way you have to go. So for this one, for the bile duct, yes, wire-guided cannulation, fine. For the PD, I don't think it's a good idea. So here, after getting in there, you can see the injection in there. And then now you saw how it went into the side branch. If I did not have a contrast, I could keep going and trying to keep push through that. And I can really cause a damage in there. So this is another example of that. Now, you know where that wire is going? It went downwards. Where did it go? Any idea? It went very smoothly. Yeah, it went to the dorsal duct. Okay. So, which is fine. You just need to change the direction. Then bringing it back. And whenever you can, if you can make a loop on the wire, that is really always good for the pancreatic orifice, pancreatic duct, I should say. Because the loop always follows the main duct. It never goes into the side branch. So if you are stuck, if the wire is stuck on the wall or in the side branch and you gently push and it starts to making a loop, let it make that loop. Then it will just go straight into the main.
Also helps you avoid perforation.
Absolutely. So that's and it always follows the main duct. It never goes into the side branch because the side branch opening is not big enough to accommodate that loop. And also, when you put a smaller stent, get rid of that loop before you put the stent. Sometimes the wire can get stuck on that. So here, you can see this is a stent in there. I think it's a pigtail. I don't remember. So neck of the pancreas, I was talking earlier, is the area just like a sigmoid colon, or not sigmoid, splenic flexure is the watershed area of the colon. Neck of the pancreas is the watershed area of the pancreas. And that has the least amount of blood supply as compared to the rest of the pancreas. So that's where the stricture develop. Most of the stricture, whatever you're going to see, are going to be really in that area, that, especially the ischemic stricture or a stricture from a stent as well. Because also, if it's a smaller stent, it doesn't cross the neck area. Every time there is a motility in the small intestine, the stent gets pushed up a little bit into the duct, and it keeps hitting that one area where there is a turn, and that's where the stricture develops because of it. So this is one of our study from our center. We just followed those, how often, like we're talking about this cannulation success, how often you need a EUS guided drainage or some other technique to get the access to the bile duct. So these were we followed these for like, I think it was 10 or 11 months, the 1,000 ERCPs. More than 500, those were native papillas. Ampulla was reached almost 99%. And you can see that the standard cannulation technique, 87%. And advanced technique may be like requiring a needle knife or putting a stent in there or doing something else, like not being able to get first time not being able to get a desired duct cannulation was 13%. Overall successful binary cannulation, 98% in native papilla. Okay? So 49 of those 1,000 ERCPs, they were like failed cannulations from outside. You can still see that standard cannulation technique more than 80%. Just like a standard cannulation is cannula or sphincterotome with the wire, nothing else. That's what I'm talking about. So advanced cannulation is like you have to put a stent, you have to use a double wire technique, or you have to do a needle knife for that. Okay. So overall, in these failed cases, cannulation success was 100%. Overall, ERCP cannulation when ampulla was reached, you can see more than 99%. Okay, and overall, native papilla ERCP failure very minimal, and you can see if then it's a cost analysis. So somebody asked yesterday how much it costs. So if a successful ERCP without any other need of any other service, then it's close to really 5,000 or so. Okay. So that's pretty much it. This is another slide. When you start doing these procedures or any kind of, you become a doctor, you like going through the training, you don't know how incompetent you are. That applies to everybody. So it's like, it's a circle. You are unconsciously incompetent. Then you get to know, oh, really, I suck at it. I really don't know. That means like now you're getting at least the real part of your life. So you know that you need to learn more. And then you become, you practice more, you spend more time, you become a competent, and eventually you get to unconsciously competent. You become a good driver. So without thinking, you keep doing. And then, I don't know, I should mention anybody, when you get to age 70, then the other circle starts again. Okay, so that's pretty much it. Yeah. Any questions?
What's the difference between needle knife and trans-sphincteric ablatomy?
Trans what?
Sphincteric ablatomy, trans-sphincteric. There is some word I read that.
It's, I think mostly it's what we call a septotomy. That's what it is. Okay. So bad idea most of the time. Okay. You really, you keep getting into the pancreatic orifice, and you want to get into the bile duct. So there is a technique, it's called a septotomy. So what you do is you use a sphincterotome, and you give a very superficial cut. It's not a cut to the sphincter, it's cut to the mucosa, and to expose the upper end of the septum. So usually you end up getting into a trouble than helping yourself. You make the opening bigger, and you do a pancreatic sphincterotomy, now you're stuck with that. So not, and then there is a term called the fistulotomy, and in that case, usually in bile duct cancer or like a pancreatic cancer, it's hard to get through the papilla in there. Then you select a space above the papilla, and then you really kind of, using your needle knife, you're trying to get into the bile duct blindly. Again, not a good idea, but that.
What do you normally do? Below up or up
Yeah,
down?
so that's I do both, depending on the
What can you
papilla.
do more?
I could do more below up.
Very interesting. I just asked you this because I was invited in Delhi for a workshop. President of India. There was a talk from one of the Indian, very senior Indian guys. He was talking about needle knife. There are three methods that have just been described. Some people would call the one that he said you go up and go down, sort of kind of fistulotomy. So this guy said, below up is not a good idea. And the audience, half of them are probably students or whatever. And septotomy is again something that you do if you are really. So and the way to do it, and then he quoted G.V. Rao, is surgically correct and this and that. So I said, I think I would accept if you said this is my preferred method. But for you to go
And criticizing
so
it,
far
yeah.
that you say based on a lot of experience. I mean, we don't do a lot of cases, but we do significant number, and we have published needle knives already. I said, no, it's not a problem. It's about what you are comfortable with. A, what is the ampulla like? I would be very worried if I have to do a needle knife in a small papilla, trying to do a fistula. You know, you're actually going here. I can literally put my needle in through the ampulla and just gently dissect. So I think the reason why I mentioned this is an anecdote, is that we all have our own preferences, but I think all techniques work in the hands that are good. So one thing might not work for you, but it might work for Khalid very well, and what Khalid might be doing, I might not be doing.
This debate happened in the PSSLD meeting, last PSSLD meeting at Qaidazan Lab. So half of the operators, they were advocating below up, and half were from
What I would like to know is how many of them were actually regularly doing that?
Brigadier Amjad was of the,
What was he saying?
he was more comfortable with the up-down.
It's what I say is like I don't start with the start cutting right away. I take my needle out, I look at the papilla, and without cautery connecting, I see what would work better. If I cut from top down, is it in the right line? If I cut from the bottom up, so I move my needle without touching it to get me an idea. So based on that, I will go with that. So that's how I do it. And mostly, I usually end up doing from bottom up. That's also kind of a Seth taught me. Yes.
Yeah,
Yeah, different words used for sin.
yeah,
That's
I
a
would-
whole different
yeah,
topic.
yeah.
They just cut it off.
Ampulectomy is not
For-
like a for cannulation. Ampulectomy is totally different. That's for the ampullary adenomas.
Polypectomy, yeah.
So that is a totally different topic. Ampulectomy is not done for the purpose of cannulation, if that's what you're asking.
I'll just make a, sorry.
Sorry, I can share our experience. I think I mentioned it to you. The paper is sitting with Ali. We've got 160 cases failed elsewhere, and we have the same results as Khalid. We've had 100% success in all. I think there are a few that required more than one procedure, but we succeeded in 100% cases. They were referred from all over the country. I mean, either directly or indirectly came to us from all over the country.
I'd just like to, sorry, yeah. I mean, before I complete. Just like to make a few points here. Number one, we did 16 cases over a span of 2-3 days.
ठीक है.
And you saw that it was 100% cannulation success without resorting to needle knife. So that's important. Secondly, जो below up or up down or जो भी है, it entirely depends on what you are good at. Do that. That's the rule for any procedure that you do. Do the procedure what you are good at. The other thing is, I follow exactly the same procedure like Khalid does, of making a dummy run on the papilla, so that you set in your mind exactly what line you are going to take for the cut. Because a badly performed needle knife sphincterotomy is a disaster. आप खुद भी कुछ achieve नहीं करते, and the person who follows you, it's a problem for him. So a badly performed, try to avoid that. Secondly, septotomy or the roofing जो है, that's clever stuff, don't touch it. और मैं खुद नहीं करता. Because I've seen people attempt it in one of our courses as well, and it was a disaster.
What is that?
वो क्या है, septotomy. क्योंकि I wouldn't name the person who did it, but we got injection into the portal vein, and he said that it was successful cannulation. It wasn't, because there was a sudden blush and it went. So don't try things that are clever stuff.
I think, one of the things that comes out very clear from this course is we've had some extent exchanges, maybe 3 cases, so 10% nikal dein. So this is now, we are now 141 cases. We have 0 failure. Today, in front of you, 16 cases, 0 needle knife. And they were not the easiest of the papillas either. I wouldn't say
But
they
these
were
were
all
very floppy
very simple.
papillas.
There were all sorts of cases that you've seen. But each case we were able to cannulate. Our problem, I may be wrong, is that we haven't taken the first step and we want to go to the third.
Which is wrong.
And that's why so many people do ERCPs in this country. Ask them to come and perform live. And you'll find out how many are willing to do it. Put them on the spot and you'll know how confident somebody is. And that's the main thing. The foundation is very important. In front of Khalid or Waqar, when you start doing something, they will immediately know in 2 minutes. Okay, na? So I think this course is your foundation. Build on this foundation. Lots of things are there to be done. Should you be doing that? I don't know. Should all of us be doing that? Absolutely not. Okay? But what we are doing, we should do correctly. That's what it is. When we started, we asked you what is the cannulation percentage? What is the cannulation percentage? Okay? I didn't ask you what it should be. We've shown you what it should be. That's your target. Nothing short. And it's a very strong statement I'm going to make. Any center that has less than, close to 90% circumcannulation should seriously think about stopping their ERCP center. That center and that person needs to go, train, and then go back. Okay? Because if most centers in this city, their patients can come to us and we can finish most cases within 20 minutes, there's a problem. Okay, so that's what you need to improve. That's why we've done this course. हमारी तो हो गई है नहीं यार, हमने तो जो करना था कर लिया.
Dr. Khalid, you mentioned about
ये एम्पोलेक्टमी देख रहे थे ना आप लोग. So it's a huge mass there. ठीक है? It's not a simple straightforward empolectomy, but
After empolectomy and then radiostat and then
yeah, because this was a laterally spreading tumor. ठीक है? और ये it's not just an ampullary area, it's extending way down. So first did the empolectomy part, put a stent in there, protected the pancreas, and then did a EMR of the rest. ठीक है?
regarding the wire
Lovely to see.
guided cannulation, I have also read the term rotatory wire
Akram?
cannulation. Is there something like that? You say rotate the wire, is it the same thing as the curved wire?
Yeah, same thing is, yeah. So, okay. Rotate the wire is this. So when you go in, like sometimes you are stuck in the papilla, you rotate the wire to give a different angle. And it's
changes the angle of the wire.
changing the angle.
When you do this,
And usually it works better with your bare hand without glove. ठीक है?
especially if you're getting problem getting into a system, you're stuck, you use it, the tip of the wire will move. You can actually see it under floor and you
If you got an angle tip,
ठीक है, done?
हाँ जी, बिल्कुल.
Akram, so we'll now, Akram will show how we clean and you can add or learn or even tell us if you're doing something differently or better. We'll do this and then we've got a couple.
और ये एक छोटा सा है. This is a real